Hello, good morning, everybody. I'm just going to give it a minute so everyone can get connected and get logged in. We will get started very soon. While we're waiting, if you guys want to say hi in the chat, go ahead and do that. Or if you want to say where you're from, I'd love to hear it. All right, looks like everyone's connected, so we'll go ahead and get started. So good morning, I'm Brianna Yoakum. I'm the Director of Accreditation with Walker. I also do the professional development aspects. That's why I'm always on these webinars. But today we have a very special guest. Her name's Thea Oliphant-Wells. She's an MSW. She works for public health in Seattle and King County. And her current focus of her work is expanding access to harm reduction services in the community and helping to facilitate a council of people who use drugs. Thea has been working in harm reduction programs, serving people and homeless in Seattle for over a decade, and she brings her lived experience with injection drug use, living homeless, and finding safety and harm reduction people and spaces. She uses both her personal and professional experience. Thea has worked to lower barriers and to care for people who are experiencing homelessness, people who use drugs, and those with trauma histories. So again, we have Thea on every year now for quite some, probably 3 or 4 years, to just share her wisdom in this realm and give us some updates. So we're really glad to have her. Everyone who's on here today, you will get an email with a survey after, usually a few days after this webinar, and we'll also attach the slides in there as well. This is also going to be recorded and updated on our Walker YouTube channel as well as our webpage. So if you have any questions during the webinar, me and Sarah are going to monitor the chat for Thea, and we'll kind of just, if it fits in with what she's saying, we'll bring it up as we go. But with that, I'll pass it on to Thea.
Good morning. Oh, I love seeing that folks are here from all over the state. I will talk a little bit about King County a lot because that's where I'm from. But I will also try and make sure there's some statewide resources put out there as well, or at least talk to them so that you're not bored, most of all, and maybe you walk away with something helpful. That's usually my plan. So yeah, I'm really excited to be with you all. Part of my recovery story, it has been having safe and stable housing through Oxford House, and so I really always try to show up for recovery housing, and also just went to a SAMHSA meeting in Denver where they brought together a bunch of recovery folks and a bunch of harm reduction folks and talked about bridging the gap between our communities. And so one of my things that was like on my follow-up list as a harm reductionist is to make sure that I'm still connecting with recovery community and yeah, bridging that gap when I can. So harm reduction is my passion, my religion, but part of my healing and wellness journey has been through recovery housing. And so it is part of my, part of my story and what's important to me. I'm going to share my screen, hopefully, and give you all a training today. Let's see. I don't see, share sound and video clip. Bear with me. It's only been, years of doing this. All right. I think I'm screen sharing. And now, why is that toolbar coming down? You guys are going to really think I'm a dodo. I can't get rid of this toolbar that's in my way of presenting my slides. Why is that? Go away. Okay, anyone know how to move this toolbar so that it's not, oh, there we go. Wow, that was embarrassing. Okay, Yay. I think we're good now. If not, oh, now the toolbar is right in the center of my screen. Okay, I think we're good. Holler if not. You already know who I am, Thea Oliphant-Wells. I was also very impressed with Brianna's ability to pronounce Oliphant, so thank you for that. It's a rare occurrence. So I'm going to be talking about the local drug supply and overdose trends and trauma-informed overdose response as an overdose survivor and one who has responded to a dozen overdoses during my life and career. I always like to talk about our best practices when it comes to welcoming folks back. And we'll talk about overdose education, how to counsel residents, and then I'll share some resources. So this again is King County specific, but I can tell you that what happens in King County, doesn't stay in King County. And so when you look at the statewide rates next to King County, just add a little bit on each bar, basically. So it's not completely reflective of the larger state, but gives you a good idea what's going on out there. So you can see that our overdose deaths primarily are opioid and stimulant, in combination, or at least found in combination in our decedents. And opioids by themselves are still, a big issue in that, like, teal color is opioids, purple is the opioid and stimulant. Stimulant only is that red part of the bar. And I think it's a really important thing to highlight. Back in my day, we said, oh, you can't overdose on meth. It's just overamping, you'll sleep it off. Well, nowadays, our meth is really killing people all by itself. And so we can't really talk about overdose and not highlight meth overdose these days. Plus, when you use meth and opioids together, I used to think back when I used both that they would balance out each other. And the reality is that they both stress your respiratory system. And so using stimulants and opioids in combination actually increases your overdose risk. These are the drugs involved in overdose deaths locally. And so you can see that dark blue is fentanyl. And since 2020, it's just skyrocketed. Also, you can see that red meth line. It's also, been a huge factor in our overdose deaths. You can see that little cocaine line, the very light or light pink or peach, starting to creep up a little bit. Some of that is due to folks who think they're buying cocaine and they really get fentanyl instead. Rather than fentanyl cut into cocaine, they're just getting the wrong product. And if you're not ready for fentanyl, that can be a big issue. So, just to give you sort of the history of fentanyl locally, in 2017, we started seeing those blues showing up. In 2020, right at the start of the pandemic, we really saw the blues flood into the community and replaced heroin as the main opioid in the street supply. In 2022, we started community drug checking programs here in Seattle, which have since gone statewide and not in every community in the state, unfortunately. But if you're interested in community drug checking, always follow up with me because it's been my latest nerd out in my position here. And in 2023, we started to see powders becoming more available than the pills and also hugely variable in the potency. So we would send pills off to a special DEA certified lab that could tell us the quantity of fentanyl in things. And we'd have pills with like 1 to 3 milligrams of fentanyl, where we'd have powders from 1 to 20 milligrams of fentanyl for 1/10 of a gram. So like really, really variable. In 2024, we started to identify industrial chemicals in our drug supply that haven't been identified by, drug checking labs before, because usually those are police. initiated tests, and they don't necessarily care about chemicals that hurt us if they're not things they can cage us behind. And so having the power of drug checking projects in community that are not police motivated, we really are looking at the health and wellness of people who use drugs, and um, we're learning a lot about our drug supply, and not in a good way, unfortunately. Oop, going too fast. So when you're talking to people about fentanyl, you can counsel them that it can be in any drug, though we don't see fentanyl in everything. For a while, there was a lot of, oh, they've cut fentanyl into all the drugs, and there's fentanyl on cannabis, which, by the way, makes absolutely no sense from a drug use perspective, because when you smoke a flower of cannabis, you put the flame right on it. And for fentanyl, that would just completely burn up the fentanyl instantly. And so there's a lot of myths out there about where you can find fentanyl. It can be anywhere. It's not likely to be found in other drugs locally. If you look at West Coast, it's a whole different ballgame. But West Coast and Washington State, our fentanyl is a little more straightforward. If you look at fentanyl samples from East Coast, you'll see all kinds of stuff mixed in. And so our drug supply is a little bit simpler. Naloxone still works to reverse a fentanyl overdose, and it's absolutely safe to respond to a fentanyl overdose. There's a lot of misinformation out there about how touching fentanyl could hurt you, or breathing near someone who's overdosed, and these are not backed up in science or evidence. Opioid overdose. So identifying an opioid overdose really is the first thing that you're going to need to do, but knowing who's at risk can also help you to know which of your residents or which of your neighbors to sort of keep an eye on. If folks are using opioids, obviously that puts them at risk. When people are in treatment for OUD, uh, including if you're on a medication for opioid use disorder, although we know that MOUD reduces overdose risk for folks who are taking it. If you have an OUD history, including folks in recovery, if you're using high dose opioids for a long time, the biggest thing is, have you survived a prior overdose? That just shows that you are susceptible to overdose, and it's pretty shocking how many times some folks have had an overdose. I really have noticed that some people are far more susceptible. If you have a reduced tolerance, like if you've just been to inpatient or jail or detox and you're not on a treatment medication, then you have no tolerance. And if you return to use, that's a really scary time. Trying to think of other ways that you would reduce tolerance, any abstinence, really. I mean, some people, quit for a couple weeks and think they can go back to using the same amount. And, that can be really problematic. And when we're talking about fentanyl and all the variability, it's even more problematic. If you are using drugs in combination, so there's sort of like the big three, alcohol, benzos, and opioids. Those are potentiating substances, which means 1 + 1 = 4 rather than 2. When you use them in combination, they enhance each other. And so it really does increase overdose risk. And like I said, the stimulants are going to stress your respiratory system and also increase risk. Signs of opioid overdose. So I always love this poster that's on the right, which we sell these on our or sell them. We distribute them on our website. They're free. If you are interested, and you can also print them off of our website, without ordering. And really, there's those 3 categories of signs to look for. Breathing changes. So their breathing may be slow, or they may not be breathing at all. most likely they're going to have some noisy sounds when they're breathing, gurgling, snoring, choking, wheezing, gasping, just really abnormal breath sounds. You can't wake the person up. You say their name, hey Joe, wake up, and they're not responding. You tap their shoulder, no response, or you may have found them in a really unusual position that doesn't seem right. And then skin changes. Skin changes will appear differently depending on your skin tone. If you have very light skin like I do, I would turn very blue. If you have very dark skin, you may look more gray or ashen, sometimes purple. And so it's important to note that not every skin tone appears the same in an opioid overdose. Also, their skin may feel cold and clammy to the touch. Let's see. Vomiting could also have be happening, though it's less likely during an active overdose. Um, and sorry about that. Sometimes the pulse will be absent. Usually there is a pulse and the breathing is affected. Once our pulse becomes faint or absent, it's a really important emergency. And we'll talk about CPR in a little bit. Everyone always asks me when I talk about overdose, how do I tell if they're just high or they're really having a medical emergency? And so I always like to sort of break this out. If somebody's on the nod, they may be very relaxed. They may be nodding out. Their speech is slurred, but they're still going to respond to stimulation. Maybe not the first stimulation, but they are going to be arousable. Um, and if someone is actively in overdose, they're not going to be able to respond to stimulation. Like we said, their breathing is going to be different. Their appearance will be different. So when you check on somebody, you see like, oh, this person looks a little bit different than normal. I feel their skin. They feel different than normal. They're not waking up. A pain stimulus is great. Some folks like a sternal rub, which is very effective. I personally prefer a trap squeeze up here. I feel like it's less personal. You're more likely to be able to do it from the side in case the person really isn't overdosing and you startle them. And sometimes boobs are in the way. I learned in one of my overdose responses. And so if you go for a trap pinch, you don't have to worry about boobs. And you're not going to be right in someone's face if they do get startled and are arousable. If you think someone is overdosing, absolutely call 911. If there's more than one person on scene, ask someone else to call 911 while you're administering the Narcan. If you have nasal naloxone, it's so simple. You really are just going to have to open the package and put your two fingers on the top, like in little picture number 2, and your thumb on the bottom, and you're just going to put it in until your fingers reach their nose. Usually we want to have the person flat on their back with their nose turned up to the sky if possible. Sometimes people are found in really unusual positions, and so that's not necessarily possible. Like if you found someone sitting in a bus seat and they're sort of squished in there, you aren't going to necessarily be able to pull them out and lay them flat, but you can just take their nose and point it to the sky before you put the naloxone in there. They don't need to be breathing for that to be absorbed. It just gets into the nasal lining. After you give a dose of naloxone, you're going to want to do rescue breaths. If the person has a pulse, you do not want to do chest compressions. We just want to focus on rescue breathing. An opioid overdose really is just shutting down your breathing. And so the best thing that we can do for people is make sure that their brain is getting adequate oxygen. And if you don't have naloxone, breathe for people. you can absolutely keep someone's brain alive with rescue breathing. And so sometimes people are like, I don't have any naloxone, I can't do anything. You absolutely can breathe for them. If they have not, returned their breathing, they don't need to sit up and run a marathon, but their breathing should return to more normal. Their skin should turn to more normal appearance and touch. If that is not happening after 2 to 3 minutes, give another dose in the opposite nostril, and then continue your rescue breaths, 20 per minute, so every 3 seconds. And that really is the most important part, is to breathe for folks. They need that oxygen. We've, had a lot of folks who survive an overdose, but their brain's dead. And we don't want that for our people. You want to stay with your person until medical help arrives. That naloxone is going to wear off in 30 to 90 minutes. And so depending on what opioids they've used, they may return medical help. If your person does not want to go, I just got to notice that my internet is unstable. So please holler if I start cutting out. Monitor them in the recovery position if they're comfortable with that. I have done a lot of like street-based overdose response where like you're not putting someone in a recovery position, but if you were in the comfort of a home, you might. And then be prepared for withdrawal symptoms. If your person has been using opioids regularly, that naloxone is going to kick all the opioids off their receptors, and they're going to feel all the withdrawal symptoms that would normally happen over several days are going to just slam into them all at once, which is called precipitated withdrawal. It's very uncomfortable. I can tell you from experience, doesn't feel good to get naloxone, though it feels great to be alive. So, but really be gentle with folks because they're going to be feeling really lousy. Now we talk about trauma-informed response, but I want to pause because I haven't even given you any chance for questions. Are there any questions so far? Want me to keep rolling?
I don't see any in the chat, but let's pause a minute and just see if anyone has any questions.
I have a question. You said that fentanyl, touching it doesn't transmit to the body. Is scientific proof of that?
The question? My daughter just woke up.
Touching fentanyl doesn't transmit it to the body?
Correct. Yeah, they spend a lot of time formulating special patches that can make it absorbable through your skin. I have mistakenly flung powder fentanyl in my face one time, being an idiot, while packaging drug samples for the lab. And because I've been working with fentanyl a long time, it was like, oh, that was a dumb thing to do. Let me just clean up real quick. Yeah, there hasn't been any science that has shown that to happen. We cannot say with certainty this could never happen in any universe. What we can say is that we've never seen scientific evidence of someone touching fentanyl and getting any kind of fentanyl effects. Does that answer the question?
Yes, ma'am. One more thing. Is there a such thing as too much naloxone?
Yes, very good question. Thank you for asking that. We definitely see over naloxone usage in some of our overdose responses. I think fentanyl has been a big player in this. Fentanyl takes a bit longer to respond to naloxone from what I've seen. And so that's a really scary situation. And sometimes people don't wait that 2 to 3 minutes and just continue to give more and more and more. The more naloxone you give, the more sick your person is going to be if they have opioid dependence. And so they used to think, well, the worse they feel, the better, because then they won't want to use anymore. which is actually not true in any means. The more that someone is experiencing withdrawal, the more likely they are to go out and seek more opioids. And so we don't want people to use more. We want people to be safe and let that naloxone wear off before they use again. But if they're really feeling sick, they're more likely to pile on the opioids and try to override that naloxone, which can be really dangerous.
We
We
had a
also,
question. Oh, go ahead, Thea. Finish what you're gonna say.
there's also a high dose formulations of naloxone, like Cloxato, which is really abusive toward people who use drugs. It's not more effective at reversing an overdose, and it leads to higher precipitated withdrawal risk, and which also leads to higher risk of death. So we definitely try to avoid those high dose naloxone. There's also a longer acting overdose reversal agent, nalmefene, which lasts a really long time, which isn't helpful, frankly.
We have a question in the chat from Christina. She says, can you explain the recovery position?
Yeah, so the recovery position is just laying on your left side, like this little guy in the picture. You roll someone onto their left side, their right leg will be bent, and it just gives people a chance to relax and breathe. I personally have never had anyone comfortable enough for a withdrawal or for a recovery position. Normally, I'm responding to overdose in community, and so people are real scared. They're not comfortable enough to just lay and recover. But if you had a calm environment, it could happen.
I have a question.
Sure.
You were saying rescue breathing. Is that like mouth to mouth? And then you said every 3 seconds?
Yeah.
Okay. Okay, just making sure.
So I usually do like breathe out 2 and then breathe in 1. And that's going to get you through your rescue breaths. And you can get a disposable mask to carry. You can use an ambu bag if you have one. A lot of
If you find
times,
them on if you find them on a bus though, I mean, you have to get them down onto the ground somehow, some way, and tilt their head back to give them out the mouth.
yeah, it's difficult if somebody is in a weird position. Usually after you give naloxone, if they're feeling a little better, some of that stiffness is going to ease up a bit. But yeah, it can be really hard in a confined space to get someone into a perfect position for rescue breathing. We just do our best. If you had to like flop someone over on their bus seat and like get some air in them somehow, you could do that. Hopefully, especially on a bus, you would have an emergency medical response pretty quickly, but depending on if you're in a rural area, that would, not happen.
I see another question in the chat, and is naloxone only meant for fentanyl?
Naloxone is meant for any opioid, but opioids only. It doesn't work on other drugs. And it's not harmful. So if you think it's an overdose, you're not 100% sure, giving naloxone is not going to affect a person who doesn't have any opioids on their receptors. So I have a friend actually who was doing a naloxone training, and she had one of the very fancy auto injectors from the early days of community distribution of naloxone. And she thought she had the demo, and she actually had the live uh, naloxone and injected in her leg during the middle of a training, which affected her not at all because she was not taking any opioids regularly. But yeah, not ideal, especially not because that's like $1,000 medication.
Christina said, is there a good place to get mouth guards for the rescue breathing?
I buy them on Amazon. You can buy a big old bag of just like the little pocket masks that come on a little keychain. Those are great. Not that I'm pushing Amazon, but they are easy to find online. All right, we'll roll into trauma-informed response, but please keep the questions coming. I just wish I could see your faces while we're talking. This video, hopefully it will work. It's really my favorite overdose response video out there.
Today, I'm going to teach you how to use Narcan, how to recognize an overdose, and how to use Narcan to reverse the overdose and save the person's life.
So the first thing to do in order to know whether or not to Narcan someone is to first be able to tell whether someone is just high or they are overdosing. So most of you have probably seen what it looks like when someone is just high. All that's happening is they are sedating. Their breathing starts to slow down, they might be leaning forward, eyes fluttering, mumbling, and all that's happening is an opioid starts to slow the body down.
But the difference between being high and overdosing is usually like a pretty thin line. And all that difference is your breathing slows down to the point where you're not getting enough oxygen or you're not breathing at all. Now we've got an overdose. And all an overdose is just the drugs overwhelming the system, right? So that's the opioids overwhelming the receptors, and then the breathing slows or stops.
You will notice two signs immediately. The first is that their skin color will start to change. So lighter skin folks will turn a bluish gray, their lips will tinge like a blue-white gray. Darker skin folks will turn like a purple or ashen gray, like the color completely drops out of them, or like they're many shades darker or many shades lighter than they usually are.
Sometimes people will be making a very telltale snore gurgle sound. That is the lungs trying to pull in a full breath, but they're unable to, right? Because they're being depressed by the opioids.
So when you see those two signs, the first, the skin color changing, and the second, the snore gurgle sounds, now you are responding to an overdose. And so the first thing that you want to do is try to stimulate them awake. Hey, my friend, you're not breathing. I think you're overdosing. Second kind of stimulation is physical stimulation. All that is administering pain.
The easiest way to give someone pain is we're going to give them a hard sternum rub. Take your knuckles and rack as hard as you can right on that breastplate. We also call it like a chest noogie. So hit them as hard as you can and start yelling their name, start telling them to wake up, warn them, hey, if you don't wake up, I'm going to Narcan you. We call that the verbal Narcanning. People who use opioids know exactly what Narcan is. If they don't need it, they don't want it, and they will tell you. Please listen to them if they tell you no. If they can say no, they don't need Narcan, right? They're alive, they're breathing.
If even the verbal Narcan fails, now you want to move on to Narcanning them. One kit looks like this, and each box has 2 of these doses. And one dose like this is just to be used one time. So what you want to do when it's time is you want to peel back the foil, take the dose out, and you want to put it all the way up that person's nose, one click, and it is all good. So you really want to make sure you put it all the way up because that person is not breathing, so they're not inhaling it in order for it to work. So you want it to go past the nose hairs into the sinuses where it can then absorb into the rest of the bloodstream.
We give out the injectable, which is just a vial in a muscling syringe. So you pop that little orange cap off, you drop out of the vial, and you hit the person either in the thigh muscle or the upper arm muscle. It has to go into a muscle to work. What it also does, if you're familiar with opioids, is that if all those opioids are pulled off the receptor and someone is dependent on opioids, they will experience the symptoms of withdrawal, and they're pretty severe and very traumatizing. If a person is not breathing and it has nothing to do with opioids and you give them Narcan, you're not going to hurt them. It just won't do anything. You don't want to give them more than 1 dose of Narcan to start. The more Narcan you give someone, the sicker they're going to be when they wake up. and it won't make it work any faster. So if I hit someone with 3 doses right out of the gate, it's still going to take 2 to 3 minutes to start working, and they may wake up feeling like shit for no reason other than you panicked.
After Narcaning them, now you want to perform rescue breathing. This is super simple. Just get that person flat on their back, tilt their chin up, pinch their nose, 1 breath, turn and watch their chest rise. Give 1 breath every 5 seconds. So in the time of COVID, right, we've gotten a lot of questions about how crucial is rescue breathing. And so we do want to name that it is pretty crucial because the one thing they're missing is oxygen. And before there was this thing called Narcan, overdose prevention trainings were all about performing rescue breathing. And also, if you're listening to this and you're like, I am not the one to do rescue breathing, just know that you might also surprise yourself with the lengths that you are willing to go when someone is not breathing and not responsive in front of you.
And so you're breathing for them, you're waiting for the Narcan to work. If you're comfortable calling 911, this is when you do it. You want to get the Narcan in before you get on the phone with 911. You know, they ask you like 7,000 questions. You don't know any of the answers to them. You just need them to get there.
But they could also be not breathing and not responsive for any number of reasons. So sometimes calling 911 and just knowing you have medical backup on the way is really helpful. So just keep it very simple. Name if you're comfortable, location, and just that person is not breathing and not responsive. After Narcaning someone, there is this myth around Narcan that when you Narcan someone, they're going to wake up pissed and they're going to wake up swinging. So what we want to assure you that at the Dope Project, for all of our 17 years of doing our work, we have never heard of someone just waking up violent. Really what's happening for folks is that they are super disoriented. So a bunch of things are slamming into them all at once. Questions like, who are you? Where am I? Where's my stuff? Where's my friends? Are you a cop? Did you call the cops? Are you going to treat me differently? And what's really happening for them is when they're waking up flat on their back, violently dope sick, surrounded by a group of terrified strangers, some of whom are in uniform, some of whom are holding them down. And I don't know about you, but if that were me, that I would also try to get away. And that is when labels like combative or resistant are put upon our people.
So waking up from an overdose can be very disorienting. People do not feel good. They are terrified. They're traumatized. And so as people start to wake up, give them some space and gently start talking to them, right? Tell them what happened. Hey, my friend, my name is Kristen. You just overdosed. We had to Narcan you. I'm so sorry you don't feel good.
Hey, my friend, this is Francis. You're here at this location. We saw you weren't breathing. We think you were overdosing. I'm so sorry. I had to give you some Narcan. I know you don't feel good right now. Sit up when you're ready. I got you. You're safe.
You're safe. You're okay. I got you, right? We call this welcoming someone back into consciousness.
And just keep on repeating that over and over to them until that person is fully awake.
And so then from there, you're just supporting them. Narcan stays bound to the receptors for about 90 minutes. And then it'll start to wear off after about 20 to 30 minutes and people will start to feel a little better. We recommend keeping an eye on folks for at least an hour and a half just to make sure they don't go back into the overdose. But for the most part, once people wake up and get past that window, they are just fine.
People who use drugs experience so much stigma for being a person who uses drugs. And so something you can do to kind of alleviate that stigma is just be like, hey, my friend, I'm so glad you are alive. Remember, nothing changes between us because what you just experienced was a medical emergency.
And then remember to be gentle with yourself and be gentle with them. Yeah, because you just went through it.
And then be sure to take care of yourself afterwards as well because you just saved a life.
I'm so sorry that I paused that video. I didn't know opening my chat was going to mess it up. Hopefully you found that video helpful. I really like the way that they talk about folks, and I think that they do a good job of highlighting some of the best practices. We want to give people space. We want to be gentle in our welcoming them back. explaining what happened. A lot of times I will try to reduce the stimulation in the space. If there's like foot traffic, have someone block people. You know, there's going to be a lot of looky-loos if you're in a more public space. But as much as you can to sort of reduce that stimulation, encourage people to stay. Definitely no shaming or arguing. I always give people physical space. I have never had anyone swing on me or act aggressively in any way, but I also know that people are traumatized and sometimes get really scared. And so I do my best to keep my own self safe and also show up for my person. And then always debrief. Always, always, always. If you ever have to respond to an overdose, even if you're alone when you respond, debrief the situation with someone you trust. Talk about what you did well. Talk about what you could have done better. You know, like it's a really scary situation in responding to an overdose. I haven't lost someone, but I've had some pretty close calls where it took a bit for the person to be revived, and that's very scary, especially when you are a person in recovery or you have a lived experience and you feel very connected to another human being. If you are in, you know, a public space, have the person that's the closest to that person stay close by. Maybe that's their friend they were with. Maybe it's their case manager. I don't know what the situation is, but if you have someone who's a safe person, make sure that person is close by. Remove extra folks, continuing emergency care. This is where that person with the most rapport can really help. I've had someone refuse to go with ambulance, but once I took them to a quiet space, just us, and I was able to explain the reasons why it's important to go for observation, then they decided to go. And so it's really important that we give people as much opportunity as the best outcome we can. If folks don't want to go with ambulance, try and keep them in a space where folks can monitor them. I used to work at a needle exchange, and so if we had someone who'd overdosed, you know, in the vicinity and didn't want to go with the ambulance, just come hang out in the exchange. I'll give you snacks and drinks, and just so we can keep an eye on you. And then, of course, always, always debrief. That's how we take care of ourselves. So, methamphetamine overdose can also be called overamping. I'm sorry that I don't have a more up-to-date meth chart, if you will, but really you can see the 10-year period between 08 and 18 where meth deaths really started climbing, and that has continued. If folks are, you know, have used too much meth, they may overheat, they may have heat stroke, they could have a heart attack or a stroke, seizure, and a lot of times we see folks in mental health crisis, and could be because they've used too much, they've used too long without a break, they've stayed up too long, they could be mixing drugs, and they could be using by themselves, which is, you know, a huge risk factor in this current drug supply. So we always want to make sure that we highlight what are the danger signs, because, you know, folks who are using meth can have a lot of bizarre behavior and maintain, right? And so really watching for the danger signs of a very hot body temperature, their heart rate is way faster than it should be, headaches, chest pain or tightness, if their limbs can't move, they won't wake up, or they may be shaking out of control. These are signs that you really do need to get some help for your person. To residents, I think it's really important to talk about language, just because Words matter more than I realized. There has actually been some really great research done at Harvard where they looked at behavioral health professionals, like highly trained, educated behavioral health professionals. And when they gave them vignettes about patients, if they talked about drug abuse versus having a substance use disorder, they were more likely to treat their patients with punitive measures and less likely to reach for evidence-based practice. So we know the words that we use to talk about our people really matter and increase stigma towards our folks. And so trying to use words that are, that don't have a negative value attached. And so if you have like a dirty UA or you failed your drug test, when I've worked in a Suboxone clinic, we would talk about urine positive for methamphetamine. Like it's nothing else, right? And it could be negative for. And usually when you try to put the value, the opposite, if that makes sense. If you're going to say negative, having it be the preferred does make a difference. We'd love to talk about people being in recovery. I certainly do. But try to avoid the using the word clean or, again, those value statements. When I first was working in the field, we would talk about opioid substitution therapy or replacement therapies. And because for a long time people looked at methadone or buprenorphine as, just substituting one drug for another, we avoid using words like substitution or replacement. These are treatment medications. They're not a replacement for your drug. So, oh, geez, it's very sensitive. When you're talking with your residents, you're going to want to cover those overdose risk factors. Have you had an overdose before? Did you recently become abstinent? Those kinds of things. Talk about those signs of overdose, those 3 main categories. What does the person look like? What is their breathing like? Oh, now I just had a blank. Who can tell me the other one? All right. You're going to talk about how to respond, administer naloxone, call 911. I like to call 911 at the same time as doing naloxone. There's a lot of back and forth over whether you should give naloxone first, then call 911. As much as you can, do both at the same time. If I am alone responding to an overdose, I'll put my phone on speakerphone and set it down. And that way I can do 2 things at once. I do not tell 911 that I have someone overdosing. That's my personal preference. I don't want police to be first on scene. I want medical people. And so for a lot of dispatch, if you say overdose, they send police first. And frankly, police are not helpful at overdose scenes. In fact, many times I've seen them make things much worse for our person that we're trying to get help for. You can talk about safer use strategies. I understand that could be a little controversial considering that you don't want people to be using in their recovery housing, but you still want to educate folks because the reality is some of us continue to use or return to use, and it's important that we have all the information that we need to keep us safe. And drug supply information is changing all the time. I have been very focused on our drug supply for the last couple of years. And yeah, it's getting wild out there. Oh no, my kitten is in heat and she's gonna start. Risk factors that reduce tolerance when someone has, discontinued using for a while, mixing drugs, if they're on prescribed medications, knowing what their risks are. If they have a history of heart, kidney, liver, or lung disease, that can actually increase their overdose risk. And so it's important just to know what people have going on medically. that previous overdose is going to be that huge risk factor. And then we know that if folks are using alone, there's no one to respond when they overdose. And so using alone can be a really unsafe scenario. If you're looking to provide overdose education with your residents, this brochure is fabulous at being able to walk people through how to respond to an overdose. And you can order those brochures for free at the ADAI Clearinghouse through University of Washington. If you just put in ADAI Clearinghouse, it comes up. And it's available in 24 languages currently, which is amazing. I've had to do community events where I had lots of different language speakers, and it's amazing if you can't communicate verbally with someone to at least be able to offer them a pamphlet in their language. Ow, this kitty is attacking me. I'm sorry.
Yeah, we had a question come in.
What is it?
A couple. So Christina asked how long someone should be monitored after Narcan, and then there's one more after that.
Yeah, I mean, it depends on how long you can. I mean, ideal would be 2 hours. That would be way further than you would think you would need. 90 minutes is sort of like it should have worn off by then. You should know what you're dealing with by then. But yeah, if you can keep someone around for a couple hours, that's their best bet, but they're probably going to want to use again for that.
And we have one more. What would you say to questions from the EMS? Have they overdosed might be among the questions.
Oh, if they ask if the person has overdosed? Yeah, I don't know. I mean, it depends on what you're working with. I usually say that the person is not breathing and not responsive. I've never had someone say, is it an overdose? But I guess they could. And, I'm not lying to EMS. I'm just trying to get the best help on scene. And so, but depending on what your community is like, I understand that I am in a more urban county. And for some folks who are in really rural areas, police may be a safe responder. They may be the only ones who are rolling around with Narcan. I have no idea what your community setup is like. And so, and what your relationship to police is like. My relationship to police is not great. So. Calling 911, it's very important. And it's good to let people know that there is the Good Samaritan law. I let people know if you're hanging out with friends and there's drugs around and someone overdoses, it's safe to call help. They're not going to you're not going to be arrested or prosecuted for possession. However, if you have a scale and bagged up drugs, I'd probably hide those. If you are on DOC supervision or you have a warrant, you will not be protected by the Good Samaritan law necessarily. And so I do like to let people know, like, these are where you're protected and this is where you're not protected. If folks need to leave a scene, please do everything you can to get help on the way first. Back in my, teenage years in the 90s, I'm dating myself, using heroin on Capitol Hill, we didn't have lay person naloxone back then. And so, nor did we have Good Samaritan law. We would just pull people outside, call 911, pull someone outside of the, home where we were using or the space, just to keep the folks inside safe or to stay away from whatever paraphernalia or products were there. Like I said, using alone is a huge risk factor. If folks have to use alone, we recommend they use a confidential service. Never use a loan line, the Brave app, Spot Check. There's a bunch of services out there currently. And so you can always give a call to one of those services before you use. Also, if you know you're going to be using alone, use in a place where someone is more likely to find you if you fall out. We always want people to start with the tester amount, especially if you get a new batch. You can always put more in, you can take it out. Um, Taking turns between using. One of the saddest situations I've seen, because I work very closely with our medical examiner here. We had one overdose scene, which, I mean, we review every other week to talk about what's happened over the time frame. And one of our scenes, which it's helpful to have people who've used drugs analyzed because we can pick up stuff that other people can't. It was very evident. There were, a group of people sitting around the coffee table. There were lines on the coffee table. To my trained eye, they look like cocaine-sized lines, whereas they were actually fentanyl. They got fentanyl instead of cocaine, which they look very similar, and it's happened a lot because they all did a line at the same time. They were all deceased sitting at the coffee table together, and there was no one to respond to their overdoses because they all used at the same time. And so if you're going to be using, taking turns, watch and wait to make sure your friends are okay. And that can really be a protective factor. You want to avoid mixing drugs. Test your drugs if you can. We have fentanyl test strips, we have benzo test strips, xylazine test strips, we have spectrometers in communities where you can take your drugs to be analyzed on a fancy science machine. And so if folks are using, please do your best to keep yourself safe. Having naloxone, getting on a medication like buprenorphine or methadone reduces your overdose risk. Another helpful brochure, should you need it, from the ADAI Clearinghouse on medications for opioid use disorder. And then some resources. So our Laced and Lethal campaign, you can go on there and find some information about fentanyl, but most importantly, a link to free naloxone anywhere in Washington State. So go for it. Though, if you're sending it to a recovery house, I have heard that sometimes they're like, no, you're an agency, this is for individuals. So just request it to yourself directly. Could be a way to get around that limitation, rather than putting whatever your organization's name is on it. I'll talk about drug checking in Washington in just a second, Michael. Super good question. This is all the links to all of that stuff for the ADAI website. If you want any of those brochures, I'm going to send my slides over to Brianna afterwards. So you'll have links to all of this stuff if you want it. There's another video at the
Roughly 2 out of 3
which,
overdosed.
You'll have. I think it's a good video. It's just not as good as the Dope Project. Hallelujah, those slides are done, and now I can see your beautiful faces and talk more about drug checking. I'm such a nerd about this stuff. So just to give you a little background on community drug checking. We have mostly at our syringe service programs, also known as needle exchanges. We've got these fancy science machines and test strips and the ability to send off to fancy labs. And so a person could bring in a sample of their drug. We usually ask, what is it? What do you think it is? Because that can sort of give us an idea of where to start. We have several test strips and reagents and things we can use, but most of all, we use an FTIR spectrometer. We put a little piece of their drug on the crystal and shoot a laser through it, and it gives us a reading, which we compare to a library. This is how we've discovered one of the weirdest chemicals we found in our fentanyl supply. We're calling it the Biz, but it has a really long chemical name, Biz 2246 tetrahyd. You know, it's a huge chemical name. Anyhow, it's a UV light absorber, which is strange. We don't know why that would be in our fentanyl supply. However, it is sold as a white powder online, so it could be just that someone had a white powder and cut it in. We don't really know. But this stuff is showing up all over the country, and it started being picked up in Portland on our FDIR machine. And so for years, we had to wait for crime labs to tell us what was in our drug supply. And there would be long, delays, and they only test for drugs that they cage people around. And so it hasn't mattered to them if there's like weird stuff, because they just worry about putting people in jail for crimes and not looking after the health and wellness of the community. So this has been one way that we've been able to take some of that power back, and let people decide for themselves what they want to use, which is, from my perspective, a wonderful thing. I want people to be as safe and well as possible, no matter what their drug use is. Of course, it's great when we find recovery and we aren't put at risk in that situation anymore, but I want everyone to, not be at risk no matter. So you can, let's see, in Washington State, there is, all of our SSPs in King County have machines, and we have a mobile project. Tacoma Needle Exchange has a spectrometer for folks in the Tacoma area. Blue Mountain Heart to Heart in Walla Walla has a machine. And I think that it travels to other Tri-Cities locations. I don't have them all, but if you contact Blue Mountain Heart to Heart, if that's your area, they will be able to direct you. Spokane got a machine, but I'm not sure how much they're doing drug checking, but that the Compassionate Addiction Treatment agency called CAT in Spokane, they may be able to hook you up with drug checking. Share in Vancouver. Everett's also getting a machine pretty quickly. So we're spreading out. We're getting in more and more communities. It's not available in every community yet, but the information should be. So the University of Washington put together a website that I don't find the most helpful, I'll just be honest. It's great for like the PhD drug nerds, but there's not a whole lot of those out there. I will put the link to their website, but they do share results for all the drug checking projects in the state on that website. I also can share with you some of the information about these weird chemicals that are showing up in things. The lab that we use for our secondary analysis, further testing, trace analysis, there's all kinds of names you could call for it, is at the University of North Carolina, Chapel Hill. And they're actually set up to do community drug checking sampling. And so they have a special page that's about the Biz and where it's showing up, and trying to really figure out what's going on with that. We also have acetamiprid, which is an insecticide, which has shown up in Seattle and New Mexico, strangely. So we're not quite sure what's going on out there, but we're doing our best to figure it out in community for the first time, which is pretty cool. Christina has a great suggestion. Yeah, check with your local health department. Hopefully your local health department can help get supplies that you need. Xylazine test strips are a little funky. Just to let you know, we had a lot of folks when BTNX first made their xylazine test strip that were very excited to be able to test for xylazine. And so they were testing meth with those test strips and getting positive results and spreading the word that there's xylazine in the meth, and there's not xylazine in the meth. Test strips are very sensitive to cross-reactivity with certain substances, and meth is one of those things. It's happened with fentanyl test strips. For a while there, everyone thought that there was fentanyl in the meth because they were testing meth at too high of a dilution ratio, not enough water. And so it was just causing a false positive. And so not to say that test strips don't have a utility. I just want to make sure that people understand that they are not great scientific tools. However, we can use them to tell us things. Just be really careful that you're mindful of appropriate dilution ratio for your local drug supply. West Coast is different than East Coast. I learned that lesson the hard way by giving people bad fentanyl test strip instructions based on another drug supply in the country. And so I know I have personally made this mistake, and that's partly why I want to make sure that other people know. Don't blow it like I did, and not give people the best directions for the tool. Now we give directions for fentanyl test strips that include testing for meth. Xylazine test strips should not test meth. That's our best advice, because it's so prone to false positive, and we haven't seen xylazine in the meth supply, so it doesn't make a whole lot of sense. And so some of these labs are willing to partner with drug user unions or mutual aid groups. And so if you're doing community work with people who use drugs, you may be able to get access to UNC lab-based testing or other things. And you can always hit me up if you want to talk about drug checking, because I really, really enjoy it. Any other questions? What are you guys seeing in your community? I always really love when I have a statewide audience. I want to know what you see out there. Oh, absolutely. I'll put my email in the chat, and it's at the end of the slides I'm going to share with Brianna as well. So if you don't save it from here, you'll get it there.
Yeah, we have another question from Joe. How effective are test strips that check for drugs on surfaces?
I don't know anything about drugs that test surfaces, honestly. I'm not sure about any of that. I don't test surfaces. I just spill drugs all over my living room, being an idiot. Really, it was one of the stupidest things I ever did, flinging fentanyl into my face. But I learned a lot about how to hold a microscope.
Any other final questions for Thea? Or any comments of what you've seen in your area? Not hearing anything.
I can just keep talking about drug checking for another 20 minutes. I'll be real bored.
Yeah, just any trends, Christina, that you've seen in the drug supply or drugs in your area. Just, yeah, anything that you've noticed in your area. I don't think any specifics.
Oh, thanks. That's so nice to hear that you got something good out of this. Yeah, I mean, with these chemical things, I think if you're talking with people who use fentanyl specifically, ask them, are you getting a weird cough? Is there weird chemically smells when you're smoking? Because we have such weird industrial chemicals popping up, we really are seeing people getting, irritated lungs and throat, and blues everywhere for hardly any money. I've been hearing it's like $1 a pill. It's insane.
Mm.
Yeah. But then now we've got people building such a tolerance to fentanyl. Now they're using 40 to 50 pills a day, which is yeah, just a lot.
Mm.
Oh, kids are using younger and younger. That's a really hard reality. Yeah, one of the cool things that we've learned in our latest research is that young people are using drugs less than they used to. The unfortunate thing is that they're dying more. And so we're losing more kids, even though less of them are using drugs than they have, previously, just because of the drug supply. The fentanyl is really yeah, hard for folks. It's a fast acting opioid. It comes in, it goes out. And so people are using more times a day than they would with heroin or another opioid. And that means, if you're using 3 times more every day, that's 3 times the risk when you're using. So yeah, it's a really hard time out there. Yeah, rural communities get hit so hard. You don't have treatment access. You a lot of times don't even have harm reduction supply access. And I really feel for our rural communities and the 911 response. I can't imagine being with someone who's not breathing and not knowing if an ambulance can get to the person in time. It's a really hard one. Definitely tell your cocaine using friends to test their cocaine for fentanyl. We have a new public health campaign out called Before the Bump, which is not about pregnancy. People are like, what? But before you do a line, test your substance. It wasn't my campaign. I'll let you know. We wanted to call it Not Your Grandma's Cocaine. That's what we call it unofficially on my team. Oh, less youth are using alcohol and more are switching to using THC. That's interesting. Probably a safer bet than alcohol. And also with some of these high potency THC things, they've done some weird stuff I've heard for young people and um, their mental health stuff. Drug testing service, animals and pets. Wait, what?
I know, I thought that was really interesting.
They test pets? That is very strange. Wow. Dang. Vaping THC in school bathrooms is huge. Ooh, I was doing cocaine in the school bathroom. I get it. Kids be using in bathrooms. Yeah, but vaping. Yeah, the drug supply has certainly changed. I mean, in the time that I have been working in the field, we've had a lot of shifts. Oh, ew. Hiding drugs in an animal sounds awful. Unless they're like wearing clothes and you hid it in their clothes. Then it sounds adorable. Huh. Yeah, we've had a lot of interesting bills from our legislators in the last couple of years. And there's a real satanic panic around fentanyl, where it seems we are doing some pretty counterproductive measures from my standpoint. But yeah, people are dying, so people are motivated to do a thing. I wish they were motivated to, do a public health thing rather than a criminal legal thing. Is anyone interested in seeing our 2023 community drug checking report? like what drugs we looked at last year? Yeah, okay. I got time with you. I'm taking advantage of. Let me pull up my report and I'll walk you through it. Which we'll have another one coming out soon that will be like first half of 2024. So this is kind of old news by now, maybe, but alrighty. Sharing, caring. All right, so this is a report back to community. This is not a public facing report. This was a report that we put together for our customers of our drug checking programs in King County so that they knew what the larger results are of the drugs that they've been bringing in for us to check. And so we only checked 551 drugs in 2023, so we know it's certainly not going to be reflective of the larger drug supply in King County because it is such a small sample size, but it gives us some ideas about what's in the drugs, and it gives people knowledge and information back, which I think is really important. You can see what we tested, mostly fentanyl and meth, cocaine, and a good mix of the party scene drugs. We tried to focus really on what the questions were that people were asking when they brought in their drugs. And those questions were, what's in the fentanyl? What's in the meth? Where do you find xylazine? Is xylazine in everything? And so really those were our focus for this first report back. And most of our fentanyl, we break it into pills or powders and rocks. We found that most of our powders and rocks are usually compressed powder. And so we lump those together. The UW does not lump those together on their website, and so you can see a little bit difference in how we present data. Of all the fentanyl pills that we tested, none of them had xylazine. So if you have people who are worried about xylazine or sensitive to xylazine for some reason, fentanyl pills much less likely to contain xylazine. Though we did see about 10% of the powders and rocks we tested were positive for xylazine. And we only have seen in that time frame xylazine sold in opioids, either fentanyl or heroin. We also had one sample for the people who are doing math that was sold as a wax. So it didn't make it into the fentanyl powder or pill category, but it is in the xylazine category. And then what's in our meth? Out of the meth that we tested, we did see several samples that were positive for MSM. We also found a bit of fentanyl in our meth samples. Most of the time it appeared to be due to cross-contamination and not like fentanyl cut into the meth. We try to ask smart questions when we're with people, like, did you put this in a used baggie that was used for something else? Stuff like that, just to get a better idea. MSM is a dietary supplement. I have tried to research what harm MSM could cause for someone who's using it in the street supply. I couldn't find any harms, direct harms, other than if it's a bulking, it's taking up space. And so if I have MSM in my meth today, it's going to be much weaker. And then I might tomorrow decide I need to use a whole lot more, and that doesn't have MSM in it. And now I've overused meth, and now, I'm having a bad time. If I overuse meth, I usually have a bad time. The cocaine that we tested, we did have a couple that had fentanyl in the cocaine, which we could be cross-contamination, could be otherwise. Most of the time, the folks who are cocaine users who overdose on fentanyl, it's because they were sold straight fentanyl and not cocaine with fentanyl. Levamisole is one of those historically problematic substances that can be mixed into cocaine. If you've been around, Pacific Northwest cocaine a while, you may remember the levamisole wounds of the about 20 years ago. It was kind of a big deal, which is why we focus. 'Cause sometimes we have folks who've been around long enough to remember levamisole causing a lot of health issues. Now we just sort of monitor it because we know its potential to cause health issues. And then for our benzos, most of the benzos that we tested were street benzos. They are not pharmaceutical grade Xanax. They are most often made to look like a Xanax, but they really contain bromazolam, which is, one of those designer benzos. It's not sold as a pharmaceutical benzo here. And so when you see bromazolam, you know that it's a non-pharmaceutical. And yeah, unfortunately, when we test with benzo test strips, like if I'm testing one of these pills, a test strip can't tell the difference between bromazolam and Xanax. And so sometimes benzo test strips can be helpful. Sometimes just a yes, no isn't the help that we need. All right. Thanks for letting me nerd out and share my little report with you. What
Thank you.
else do you need to find? If you're in King County and you need naloxone or fentanyl test strips, we've got vending machines that have free supplies for you. I know that North Central Washington also has some vending machines. Tacoma has some vending machines. And so hopefully you have access. If for some reason you are in a space where you have no access to naloxone, and you really need it, just call me, email me. We'll find you some naloxone. Want to make sure that everybody has what they need out there. And most of all, love, just love on your people, love on each other. It's been a really hard time for all of us that live and work around people who use drugs and people in recovery. We've lost a lot of people. And so really just taking the time to check in on each other can be a really valuable, thing to do.
Okay.
So 8 minutes of your day back.
Any final questions before we close? See some thank yous. Sandra, I see a question come in.
Test strips in Snohomish County used to make me so mad. When I ran our test strip distribution, I'd get requests from Snohomish County a lot. Last I checked, the exchange up there was not carrying fentanyl test strips, but I will admit I have not checked in with them lately. Needle exchange is usually your best bet for a resource like test strips. So, yeah, makes me really upset that that doesn't work out. You could also contact the state's Department of Health. They have a drug user health team over there. I don't know how often they're able to connect people with test strips, but it might be a resource. Good, Christina, please reach out. Law enforcement can't carry it. That's not good. They should have a budget for naloxone. And they shouldn't be taking our budgets for naloxone. Cop money for cop stuff. I learned that from my friend in Nevada. Sorry if there's any police in the space. I didn't mean to disparage y'all today. All right. Thank
Okay.
you. so much.
Yeah, with that, thanks so much, Thea, for presenting, and I will have a survey and the slides attached for everyone who's on here today. Feel free to reach out if any questions come up. Thank you so much. Thanks, Thea. Have a good day.